دوت في حوالي 150 حالة، فانتوا خدتوا تلته بس، هتاخدوا التلت بتاعه دلوقتي التاني والتلت التالت لصاحب النصيب. نبتدي. يعني أتوسل إليك أبوس إيدك تقول إيه هو نوع الفحص. أوكي، أو أنا ممكن أريحك وأقول إيه هو نوع الفحص وبعدين أنت تجاوب. ماشي؟ طيب. MRI of the brain sagittal T1 post contrast showing space occupying lesion in the cerebellum, and the lesion is cystic with an enhancing mural nodule. Possibilities: cerebellar hemorrhage, hemangioblastoma, meningioma, ependymoma, pilocytic astrocytoma, neurocytoma. Pilocytic astrocytoma, the most common cystic lesion in the posterior fossa in the pediatric age group showing an enhancing mural nodule is the pilocytic astrocytoma. And it is evident that this is a child. Okay. Axial T2, T1 post contrast MR angiography of the brain. Where is the lesion? This is the lesion, and it appears of mixed signal intensities in the T2 weighted image, and after injection of contrast it shows some enhancement, and in the MR angiography you cannot see the lesion. What do you think? Normal. Yes, very good. And you see a part of the lesion. This is an aneurysm with a partially thrombosed lumen. This is the patent lumen, and the rest of the aneurysmal mass is not seen on angiography, and denoting that there is a thrombus. And whenever you inject contrast material and you got some turbulence of the contrast inside the aneurysm, and this is a helpful sign. And also one of the helpful signs is the whirly appearance in the T2 weighted image, which is the result of turbulence of flow inside the aneurysm, and it is located along the middle cerebral artery distribution, as you can see in the MR images and also in the MR angiography. Okay. Axial T1, T2, flare and the contrast enhanced MRI of the brain. Yes, and you can see the answer is written below the images. This is a brainstem glioma, and a space occupying lesion inside the brainstem. Looks low signal in the T1, high signal in the T2, and the flare with evident contrast enhancement. And you know that the brainstem glioma is commonly of the diffuse type, which does not enhance, but some of the gliomas, about 50% of brainstem gliomas, show contrast enhancement, and this indicates a high-grade malignancy, and at that time it will be a glioblastoma multiforme. And if the brainstem glioma did not enhance, it is of the diffuse type. If it is enhanced heterogeneously, then it is of the high-grade glioblastoma type. And this is a male patient, 18 years old, with end-stage renal disease secondary to focal segmental glomerulosclerosis. Breast. The CT scan of the brain without contrast enhancement showed bilateral, symmetrical, mainly posterior, hypodense areas in the posterior parietal regions, and there is no significant mass effect. Then, considering the patient clinical condition, the diagnosis is posterior reversible encephalopathy due to increase in the blood pressure due to the renal state of the patient. Axial T1 before and after contrast injection. Leave me alone. And you don't say that in the exam. Leave me alone. This is developmental venous anomaly. The developmental venous anomaly is a tuft of small veins draining normal brain tissue. It is not an arteriovenous malformation. It is clearly seen after injection of contrast because of the very slow blood flow inside the lesion. And this lesion should not be resected or embolized because it is draining normal brain tissue. MRI of the brain, axial T2, axial flare, and diffusion. There is a cerebellopontine angle space occupying lesion on the left side. Where is the description, which is extremely required in the exam? And you should say that the lesion showed bright signal in the T2, intermediate signal in the FLAIR images with restricted diffusion, and this fits very good with epidermoid cyst. Okay. Axial T2 and T1 after contrast enhancement of the posterior fossa in a female patient 50 years old with right-sided facial pain. What is the description of this lesion? Big cystic multilocular lesion at the cerebellopontine angle region showing bright signal in the T2 weighted image with internal septations of intermediate signal. After injection of contrast material, there is enhancement of the wall of the lesion as well as the internal septations and the component of the lesion extending inside the internal auditory canal. Diagnostic of okay, and this is acoustic schwannoma. Schwannoma has a tendency for cystic changes. And epidermoid cysts do not enhance and do not extend inside the internal auditory canal. Axial non-contrast CT scan of the brain. Minimal description, please. Please, minimal description. Without contrast. Yeah. without contrast. Yes, if this is without contrast scan, then this is hemorrhage in the subarachnoid space, in the suprasellar cistern, and inside the false ventricle. And you see this faint hyperdensity in the region of the suprasellar area, which is highly suggestive of being an aneurysm. And this aneurysm is leaking blood in the subarachnoid space, and the confirmation was not obtained by selective angiography of the carotid artery, and you see the aneurysm itself. Then you should expect that the aneurysm will be of relative hypodensity compared to the blood in the subarachnoid space, because there is minimal flow inside the aneurysm. Okay. This is axial CT scan of the brain with contrast enhancement in a 33 years old male presented by confusion and right-sided weakness. With or without, it does not make a difference. Describe. If this is an intraventricular mass or extra, it's extra because of the compression of the ventricle adjacent to the lesion. Then you have a well-defined, homogeneously enhanced or hyperdense space-occupying lesion, intimately related to the wall of the left lateral ventricle, surrounded by some perifocal brain edema. Okay, and this is the homogeneously enhanced lesion without tuor. Yes, it looks like as if it is extending inside the ventricle because of the compression on the ventricular wall. But the sign is very important. If you see a lesion like this, and you assume that this lesion is inside the ventricle should be dilated. And of course, the absence of perifocal brain edema. LCL, non-contrast CT or contrast enhanced CT scan of the brain showing this is enhancement. This is calcium. It looks similar to the calcareal bones. And this is a densely calcified space-occupying lesion in the left frontal lobe, surrounded by some perifocal brain edema compressing the ventricles. Oligodendroglioma. The calcium in the arteriovenous malformation is not that heavy. It's just linear pattern of calcification, and the AVM do not exert a mass effect unless it is associated with hemorrhage. Yes, calcium in the Sturge Weber should be in the gyral distribution on the surface of the hemisphere, but this is parenchyma inside the brain parenchyma. Axial CT scan of the brain with contrast injection showing what? Multiple small cystic lesions scattered throughout the brain parenchyma with characteristic central dot sign, or a cyst with a dot sign, which is classic for cysticercosis. And it is enough to see the dot in one of the cysts only. Then all the cysts which do not contain dots are belonging to the same disease. Sagittal T1 weighted images image after injection of contrast material of the brain, and you see multiple lesions enhancing, multiple homogeneously enhancing lesions in the corpus callosum and in the superior and inferior aspects of the brain. What do you think? This is not meningiomas because this one has no dural base, at least. And then you think of lymphoma because of the homogeneous enhancement. And these are not aneurysms, of course, but if you know that the patient had breast cancer, then these are metastases. Without this history, you consider the two possibilities, deposits and lymphoma. Axial brain images, T1, T2, flare, and diffusion. Showing multiple periventricular foci of bright T2 and flare signal. The lesions are hardly discriminated in the T1 weighted images, and they show no diffusion restriction. The diagnosis is MS in a female patient, 63 years old, normal brain imaging, or subcortical arteriosclerotic encephalopathy. Subcortical arteriosclerotic encephalopathy, meaning that there are ischemic foci of old duration. CT, axial T1, T2, and enhanced MRI of the brain. Adrenoleukodystrophy. Yes, but you should say that there is bilateral symmetrical white matter abnormality located posteriorly around the trigone and occipital horns of the lateral ventricles. The abnormality appears hypodense in the CT image and low signal in the T1, high signal in the T2, with characteristic marginal post-contrast enhancement, diagnostic of adrenoleukodystrophy, and this is one of the leukodystrophies that can be diagnosed easily from imaging. Coronal CT scan of the brain showing what? Connection, post-contraction, post-infraction. Encephalic cyst. Showing a cystic CSF containing lesion in the right frontal area connected directly to the adjacent part of the right lateral ventricle. Diagnostic of encephalic cyst. No evidence of surrounding perifocal brain edema or mass effect or enhancement. Axial flare image of the brain in a patient 33 years old, showing multiple periventricular white matter foci of high signal in the flare images exerting no mass effect and are not surrounded by edema. The diagnosis is MS. This is a male patient, 31 years old, presented by fever associated with mental confusion. And this is the axial T2, axial flare, and diffusion. Encephalitis, and this is herpes encephalitis being in the temporal area, and you can see that a lesion is seen in the diffusion, not seen clearly in the MR images, and the inflammation like herpes will produce restricted diffusion. Female, 43 years old, with this lesion in the cerebellum. It is heterogeneously enhanced, surrounded by extensive perifocal brain edema. Metastasis is one of the possibilities. Other possibilities, glioblastoma multiforme. Other possibility, lymphoma in an immune-compromised patient. Lymphoma, metastasis, and glioma are considered in the differential diagnosis of heterogeneous enhancing lesions in the brain surrounded by significant perifocal brain edema. And if the patient is known to have breast cancer, then the diagnosis is cerebellar palsy. 60 years old female suspected to have metabolic encephalopathy, and this is axial T2, and this is axial flare, and this is axial T2 also. Showing a diffuse area of increased signal in the T2 and the flare weighted images in the pons, with minor similar changes in the basal ganglia and thalamus. Yes, central and pontine and extra pontine myelinolysis أو osmotic demyelination syndrome. DSA aided selective internal carotid angiogram, frontal view. Hello? Yes, this is selective injection on one side. Selective left internal carotid angiogram. Where is the aneurysm? Where? This? No, this is the kink in the artery, and this is also kink. No, this is normal caliber. Yes, and this is normal internal carotid angiogram. Yes. Okay. Axial CT scan of the brain without intravenous contrast injection showing a large extraaxial subdural mainly hypodense collection with some internal hyperdensities is seen overlying the surface of the left cerebral hemisphere, associated with significant mass effect in the form of effacement of the cortical sulci, compression of the left lateral ventricle, and the contralateral shift of the midline structures. Diagnostic of chronic or subacute or mixed subdural hematoma. 64 years old female with this lesion in the posterior part of the bones. What do you think? Yes, and this lesion is very characteristic because of the low signal jet black hemosiderin rim. Diagnostic of brainstem cavernoma. The most common presenting symptom of cavernoma is seizures, but brainstem cavernoma never present by seizures, but present by brainstem symptoms. Axial T1 post-contrast MR image of the brain. Glioblastoma multiforme, heterogeneously or marginally enhancing lesion with necrotic center. Diagnostic of glioblastoma multiforme. Alcoholic male patient. Thiamine deficiency. And you should describe the lesion, and this is very important. And you got these three images, flare images of the brain with very aqueductal high signal intensity and in high signal intensity in the region of the mammillary bodies are also along the third ventricle, affecting the medial aspect of the thalami, and this is even without this history is diagnostic of vernix encephalopathy. And these are two similar diseases, but with minor difference. This patient and another one, both have periventricular white matter signal abnormalities. These are FLAIR images, and the signal abnormalities do not exert significant mass effect, which is diagnostic of. These are all patients. Yes, and this is subcortical arteriosclerotic encephalopathy of this patient, and this one and if you look carefully and you see the temporal lobes are affected in this patient, they are not affected in this patient. It's not in this area at all. I said that the only difference between subcortical arteriosclerotic leukoencephalopathy and CADASIL is the involvement of the temporal lobes in patients with CADASIL, which is an inherited disease, affects patients at a younger age compared to the age of the arteriosclerotic encephalopathy. The only difference in imaging is involvement of the temporal lobes, which are not involved in arteriosclerotic encephalopathy until very, very late. Okay? Axial CT scan of the brain without contrast showing an extraaxial subdural collection of mixed hypo and hyperdensity covering the surface of the right cerebral hemisphere, extending into the falx posteriorly and anteriorly. Diagnostic of subacute subdural hematoma. Axial T2, T1 post-contrast diffusion ADC of a child with headache, showing a space-occupying lesion centered to the region of the fourth ventricle. What do you think? What do you think? Ependymoma or medulloblastoma or astrocytoma or metastasis? This is diffusion, meaning that the lesion is restricted diffusion. The only midline space-occupying lesion in the posterior fossa with restricted diffusion is medulloblastoma. Male, 64 years old with headache. Axial T1, all these images, T1 weighted images showing normal finding. Normal. Is there a lesion? Left or right? Left. This one? Do you think this one? Yes. And this is high signal intensity corresponding to the dural sinuses. This is the sigmoid sinus, and this is the internal jugular vein, and this is the transverse sinus. Whenever you see a high signal intensity, persistent high signal intensity, the dural sinuses, meaning that dural sinus thrombosis, the most common presenting symptom of dural sinus thrombosis is headache, followed by seizures. Axial non-contrast CT scan of the brain, scans of the brain showing bilateral, almost symmetrical calcification in the dentate nuclei, diagnostic of bilateral basal ganglia calcification for the differential diagnosis. 63 years old male comatose. Axial, axial non-contrast CT brain scan showing, yes, hematoma in the brainstem, hyperdense hematoma in the brainstem extending into the fourth ventricle, and this is brainstem hemorrhage with intraventricular extension. Coronal MR venography of the brain showing absence of signal in and the left transverse sinus, diagnostic of sinus thrombosis. Axial CT scan of the brain without contrast showing extensive periventricular calcification intimately related to the wall of the ventricle, diagnostic of cytomegalovirus or toxoplasma. This was proved to be toxoplasma. Female, a child 3 years old with 1 week history of left-sided weakness. Axial T2 of the brain. Yes, and you say Nabasha in the exam. This is not very good. What do you mean by Nabasha? Yes, the puff of smoke, which is characteristic of which disease. Yes, and this is moya disease. Instead of you see the branches of the circle of Willis, instead of identifying the middle cerebral, anterior cerebral, and you cannot see these vessels. Instead, and you can see minute vessels in the region of the thalami and also in the suprasellar cistern, diagnostic of moya disease. And moya can be primary of unknown etiology, can be secondary in patients with neurofibromatosis type 1, sickle cell anemia, and radiation necrosis and radiation to the brain. This is axial axial CT scan of the brain without contrast in a male patient, 27 years old. This is not calcium, this is blood. And I have said, if you see blood in abnormal age or abnormal site, then you suspect an underlying pathology, which is one of two, adenoma or arteriovenous malformation. And this is intracranial hematoma because of the young age and the abnormal location. This is not a typical location for hemorrhage, hypertensive hemorrhage, I mean. Then you suspect an underlying arteriovenous malformation. Axial T1 fat set, post-contrast, CT scan, MRI after injection of contrast showing the posterior fossa with a big cystic space-occupying lesion showing some marginal enhancement of the cyst. What do you think? What do you mean by fat set? Fat set, the image is obtained after injection of contrast with fat saturation. And what do you think of this lesion? Glioma? Pilocytic astrocytoma? Wow. I have said that there are many exceptions for the pilocytic astrocytoma, including the small size or the big size of the nodule, the presence of internal septation, the presence of enhancement of the wall, the presence of internal hemorrhage inside the tumor, the presence of diffusion of contrast material inside the tumor. Then the most common cystic lesion in the posterior fossa of a child is pilocytic astrocytoma. شكلها ايه؟ معلش. Female 51 years old with right-sided weakness, and CT scan of the brain after contrast showing marginally enhancing lesion in the left frontal lobe with non-uniform thickness of the enhancing margin and little perifocal brain edema. What do you think? Glioblastoma multiforme. And this is this patient with anaplastic astrocytoma treated by surgery and irradiation. And okay, look to the curve. To the curve. The highest peak in the curve is lactate, and NAA is low. Choline is relatively low. Creatine does not show any significant change. Then, if this is recurrence, the choline should be high. But yes, it's high, but not that high for malignancy. And you assume that this is radiation necrosis. Sorry. Yes, yeah. And you remember the case I presented where you got mixture of the tumor and the radiation necrosis. But the best way for judgment is to look for the choline creatine ratio. If it is big, if it is more than 3, you consider that this is tumor recurrence. If it's low, then you consider radiation necrosis. And there is a good chance that there is an overlap between both. You got mixture of the tumor and radiation necrosis. This is a 33 years old male with multiple high signal foci in the FLAIR image around the ventricle. They are not seen in the T1 and they are not showing diffusion restriction. Diagnostic of subcortical arteriosclerotic encephalopathy. And whenever you see a subcortical arteriosclerotic encephalopathy and you have the full exam, look for the temporal lobes. If the temporal lobes are involved, and you think of CADASI. Female patient, 41 years old, with history of head trauma, showing an epidural hematoma on the right side and subarachnoid hemorrhage on the left side, together with some sort of brain edema underlying the hemorrhage itself. Then epidural and subdural and subarachnoid hemorrhage can exist together in a traumatized patient, or any combination of this can be also seen. Female, 37 years old, with this is T2 and this is T1 post contrast. Effective MS. I have said, and you look carefully for the enhancing edge. which is sometimes the classic for the incomplete ring sign. Sometimes, but in these lesions, they are very big with significant no edema around. You may consider this possibility, in particular in this age group. هذا بالله التوفيق.